It is Magic Monday again. Hey, Danny, how you doing today?
Hey, Ed, hanging in there. We're doing really good. How are you?
We're all surviving the general state of the world. Today, we are going to talk about ketamine on the Overrun again. But here's the reason we're doing it. Two studies have come out in the past couple months. One came out actually today as we're recording this on April 16th. So
Piping hot.
brandy new stuff. So let's go back to December and talk about this first study that we want to talk about. This came out of West Palm Beach. This is Shepke et al. A couple friends of the show that are on this paper. Dr. Paul Pepe, who's one of the Eagles. We've seen him at many conferences. Peter Antevi's been on the show. Brumley Crow's been on the show. A lot of really, amateurs at
Yeah,
EMS
these
data,
are.
as we
I'm really
always say.
excited to hear from these newbies.
Yeah,
Names you haven't heard before if you're in emergency medicine or EMS. But hey, go
yeah,
with it.
yeah. Rank amateurs. But not to add too much of a bias to it. So this is coming out of Critical Care Explorations. Again, this is December of 2024. Effectiveness of ketamine as a rescue drug for patients experiencing benzodiazepine-resistant status epilepticus in the pre-hospital setting, which is a very
Take a breath.
wordy title for a paper. But what do we love about this? It's in the pre-hospital setting. These are pre-hospital physicians who did a pre-hospital paper about pre-hospital patients, and they track their outcomes. I love this. So, real quick overview here. This paper looked at one system. And again, we say this all the time. If you've seen one system, you've seen one system, but bear with us. We're going to get into how this affects everybody. So one system, a population of 961,000 in about 1,800 square miles. And essentially the patients were just those who got ketamine for persistent seizures. They give the doses here. They had, and this 100 milligrams of ketamine, IV, IO, IM, or IN, and 1 milligram per kilogram for kids. They had 81 total cases, 57 received midazolam and ketamine rapidly terminated convulsions in 56 of these 57 patients. That is 98% conversion. And then here, they only saw some small effects. They even had patients where they gave ketamine with no midazolam, and that terminated the convulsions. The conclusion of this study, ketamine appeared to be consistently effective in treating adults with ongoing out-of-hospital seizures that were resistant to sufficient dosings of midazolam. Similar results were observed in children and adolescents. Dan, we have a pre-hospital paper that talks about how good ketamine is. If ever there was a paper that was made for the Overrun, I can't think of one. But this is, again, this
We're
is one
adopting
system.
this paper. This is our paper.
This is our paper. So again, this is one system. This is 81 cases. So you can say that it's maybe a little bit underpowered, but it was pretty exciting to see this paper.
Yeah, slightly underpowered. I mean, not a huge number of people, but on the other hand, these numbers and these percentages are really, really strong. We've all been in situations where we've treated status epilepticus. You probably see it more than you think you do, because the definition of status epilepticus is 2 seizures in a row, or a seizure, no return to baseline, and another seizure. You've got status ep. And we know that status epilepticus causes increased morbidity, mortality, causes more brain damage. This is not good. Terminating seizures in the field is something we've got to get really, really good at, because we can make a better outcome for patients. For I see patients where, hey, you know what? Maybe they've been given Diastat at home and they're still seizing, and we give them midazolam and they're still seizing. And now what? Well, in the past, maybe we would have gone to, hey, give another dose of midazolam or trilorazepam. Some people like Ativan because, hey, it's oil soluble or fat soluble, tends to last longer in the body, has a little bit more of a longer effect. But now we've got a whole nother way to attack seizures with a drug that does things completely differently. It's almost as if a vector change here, right? We're literally just changing the formulation, and maybe that's enough to really terminate the seizure. I noticed that there was kind of a little bit of a problem with some hypoxia. I think they said 22%. I'd really like to know what the causes of the hypoxia was. Was it a matter of somebody just not paying attention? Did a probe fall off? I mean, we all know that there's so many things that can happen in the back of a truck or in the resus bay. I really like to drill down into why that happened, but hey, look, if you're giving people these types of medications, I think if you have them on capnography, if you have them on SpO2, and you're watching this and you're prepared to ventilate them if you need to, I don't see this as a big problem.
Yeah, I think that's right. And the 22% is actually from this other paper that we're looking at today. This is from Finney et al. It includes Michael Perlmutter as well. So what this looked at, and this came out today, April 16th, as we're reviewing this, or as we're doing this recording, this is from Pre-Hospital Emergency Care. And what this looked at, again, this was refractory. This is pre-hospital ketamine administration in benzodiazepine refractory status epilepticus, a case series review. So again, this is a different type of study, but again, it looked at ketamine for these refractory seizures. This is 42 patients from the ages of 8 months to 79 years, similar routes of administration. Ketamine stopped the seizures in 90.5% of patients. Here we see transient hypoxia in 22% of the patients in this actual study. What the issue with this transient hypoxia is that it's 9 patients. So again, this is one of those kind of hangups you can see when a study is a little bit underpowered. But what I think is important to take from all of this is now we have one large system that looked at this, and then independently we have another group that looked at a similar type of study, and we see similar results. So we've kind of on this show, we've been whoring for ketamine for years. I mean, years ago, we had Dr. Mark Merlin on talking about how there's probably more reasons to give ketamine than to not give ketamine. And, you know, when it first came forward in RSI, this is a big thing for all of us, right? But now I hate to say like the data is extant, right? There's always more studies.
You love
there's
saying
always,
that. Stop it.
I do. But there's always more studies. There's always more people, right? And even now we're only talking about 120, 130 patients. But at some point, you have to start looking at the preponderance of the data, right? Where now we have these 2 independent studies that looked at similar things all by themselves. I'm sure there's more data that's going to come out. There's more studies that are going to be, especially with the Ativan shortage that we have now, because we have to find alternative means to treat these seizures. So I know that more is going to come out, but given the way that ketamine works and the way that benzodiazepines work for seizure suppression, it seems to make sense that, you know, changing that NMDA cascade reduces the seizure or increases the seizure threshold and reduces the amount of seizures. That's just how it works. So seeing this data is really, really encouraging. Now that we've seen these data and we see that there's a little bit of a chance of transient hypoxia in this current April study, there was 1 patient who was intubated and 13 patients needed bag valve masks. 3 needed supraglottic airways. 1 patient got intubated, which reinforces the importance of making sure your patient is still breathing. Right. So if we're saying chemically, we've decided ketamine works, right? Patients having a seizure, it's refractory to Versed or whatever we gave them, give them ketamine. It's probably going to stop the seizure. But that's where the importance of monitoring your patient afterward comes into play.
Yeah, 100%. Couldn't have said it better myself. Anytime you give somebody that's a medication that's going to alter their sensorium, there is a chance of respiratory depression. If you're not watching it, that can progress to hypoxia. Here's the good news. If you're on top of it and paying attention to it, not as much of a problem. I've had situations where I've given ketamine and they've stopped breathing. And I know everybody says, you're not supposed to be able to do that or whatever, you know, but the fact is it happens. And being prepared for it's your best defense. So capnography, watch your SpO2. If you think you need to bag them a little bit, bag them. It's not going to hurt them for the short term. But I do like this.
This is that planning phase, right? Where you have you're like, okay, maybe we're going to have to hyperoxygenate them because we might have to intubate them, right? And again, depending on how you're set up, you're already taking out ketamine. Right. So you might already have your paralytics there and ready for you. So this might add to that compendium of, all right, we need to have these orders for the seizures. And as long as we're using ketamine, let's go ahead and get RSI orders too, just to kind of cover your bases. Because status ep could also be a bleed that you're not really sure. So this is an area that needs to be controlled.
Absolutely. You know, prior prepreparation prevents poor performance. And we know this. It
say that 5 times fast. Eh?
No way. But it reveals it all the time, right? When we're paying attention to this stuff. And I really like this. This is going to be a practice changing thing to me, because now if I know that the patient has gotten a benzodiazepine before I got there and now they're seizing again, I may call and have a talk with the doc and say, hey, I want to give ketamine. I want to do this because they've already had benzos. It's refractory, not going to get a lot of benefit out of it, loading them with more benzos. We don't usually carry Keppra at our shop. I don't know a lot of pre-hospital places that do. So that's not an option. And nobody's doing nobody carries Delanton. So
you're right.
You know, this is what we have,
and again,
but it's a great option.
And as far as the practice changing thing is concerned, even if you're not planning on changing your practice, this is something you can have in the back of your mind, right? Because if you have someone who has status ep and they continue to seize, you know you're going to have to control their airway at some point, right? So I almost think, like I said, when you're looking through that progression, you might have to give them ketamine in the first place, right? So as long as you're going to give them ketamine to facilitate the RSI, this might be, all right, now I'm actually thinking of a DSI type of protocol, right? Where I give ketamine and maybe I watch them for another minute or two, you know what I mean? To see how the seizures have stopped. You know what I'm saying?
But here's another idea that's going to blow your mind.
I'm ready.
We're already starting to see papers that show that ketamine has a neuroprotective effect. How is that going to help people with seizures? That's potentially a real big game changer. Right. Nobody's studying it, but hint, hint, give it a shot.
Yeah. Stay tuned. In 5 years, we'll have all these solutions.
In 5 years, we'll be still here whoring for ketamine. And
Absolutely. All day. Ketamine today, ketamine tomorrow, ketamine forever. All right. For the Monday Afternoon Journal Club, thanks for watching. I'm Ed Bowder. He's Dan Schwester. Be sure to check out all of our stuff on YouTube and EMS1 at overrunproductions.com and on TikTok and Spotify and everywhere that we do all of our content. But subscribe down below as well. Make sure that you check out all of our stuff here on YouTube. For the Monday Afternoon Journal Club, we will talk to you all next week.
Take care.